Hi there. My name is Dr. Chuck Weber. I am the founder and chief medical officer of the Family Care Center. I want to thank you all for making the time to listen to our introduction, our demonstration. I have our TMS Tech and Regional Trainer for TMS. This is Alex. He'll be helping me out here. So I don't really read my slides, so I'm going to make sure that you guys have some time to kind of look at that. But we did start in 2016 after I retired out of the military. I was chief of behavioral health over at Fort Carson, Colorado, and I saw a desperate need for military family members, their veterans, and the whole community. I got some investors in about 2020, and they brought a world-class team that kind of helped me sophisticate myself to such a degree, moving from 5 clinics to now 15 over just the last 2 years. So we've grown very significantly. Really what I'm trying to do is to try to make a difference in the community. And as a psychiatrist, we're always kind of struggling. We can't ever do this alone, right? So each one of our clinics have about 15 providers. So there'll be 10 talk therapists, varying kind of evidence-based medicine that we're doing, as well as a psychiatrist and other nurse practitioners and PAs, and a TMS machine. So I wanted to have everything under one roof for outpatient behavioral health to take care of that community. And we wanted to be in the communities where the need was. So they didn't have to go very far. We learned a lot of these things in the military, what worked and what didn't work. And I wanted to try to bring it together and civilianize it. And we've got an excellent model. And what we really try to focus on is being provider-centric. Provider-centric, by taking care of the providers and our employees, we really create an environment. They want to come to work. They want to actually deliver care, and they make it patient-centered. So that's kind of an overview a bit of the Family Care Center. All right. All right. So I don't know everybody's background, and just to kind of reiterate with what Trevor said, if you have a question, go ahead and we'll send it, and we'll, if it's appropriate for that particular moment, then we'll answer it then, and if not, we'll see it. So this is just a little bit of overview of major depression disorder. And the biggest thing with this is a lot of the patients out there, a lot of our population, they're underdiagnosed, they're not getting treated, or they get treated by their primary care. And usually a lot of those are really struggling with trying to take that comprehensive care of talk therapy, biological, which is the medications, social, which is going to be their environment. And then of course there's a spiritual component to all that. So what this is really kind of showing is that, Colorado really struggles. I mean, if we're number 7, what that means is we're a little bit close to 20 per 100K of suicides, right? So 20 suicides per 100K of the population. So very, very high percentage. And you can even see we're going into Texas and Tennessee. It might look like a lot smaller, of course, 36. But that's still around 14 per 100K, which is around the average. In other words, depression is huge in our society, especially post-COVID, especially the things that are going on in the world today. And so as a number one aspect of what we can do with depression, right, is different kind of treatment modalities. And so I want to show you TMS. Okay? All right, so there's a lot of different ways that we can treat people, right? We treat people with meds, with talk therapy. We can change their environment. There's a huge aspect of that, and of course, that spiritual component. Here are some other aspects, which we are calling deep brain stimulation. That is actually very, very invasive. And it goes into your brain. So you actually have a device in there. All right, we have vagus nerve stimulation, also good evidence with that. All right, but once again, this is another device that is going on. And then we're going to talk about repetitive TMS and intermittent theta bursts as well. And of course, we have this the Transcranial Direct, which I think that there are some devices you can buy on the just out there, online as well. And so those don't have as much efficacy. And what I want to show you is that TMS, when they're coupled with the therapy and they're coupled with good med management, that we can have an incredible response and hopefully get them off. So a little bit about TMS, right? So Dr. Anthony Barker here, he is still alive. He's still very involved with the TMS Clinical Society. He kind of made the first machine with another engineer. And what this study was how we can actually create an action potential. How can we change neuronal activity, right? And that's kind of what we're doing. Well, that's exactly what we're doing, both for med management and also for talk therapy. we're actually changing the brain structure for neuromodulation. And a lot of this is based on very, very old physics, right? This is Maxwell's equation and Faraday's law, which is, in basic terms, is that a magnetic current creates an electric charge. So what TMS is going to do is going to find those areas, and we have some slides later on of those areas that are not active or they are overactive, and the way that we both approach it in the anatomy and also on the hertz and modulation and how many treatment protocols are needed is going to change the activity in the brain. You guys can remember, or if people know, everyone's heard Prozac, right? So Prozac is usually affecting just serotonin, which is our mood-enhancing neurotransmitter. And most of the times with Prozac, what you have is you have it's a reuptake inhibitor, right? And so that neuron that is having an electrical activity, it goes to the next electrical activity of the next neuron next to it. And so what the Prozac is doing is blocking the garbage disposal system. It's probably the easiest way to say it. So that chemical stays in the middle, the cleft, a little bit longer, and then it increases mood. So what the TMS is going to do is induce electrical charge on both sides and hit all of the neuroreceptors that are in that particular area. I'll go through that a little bit. So how does it do that? Well, there's a lot of different coils, and we'll show you a few that we have here at Family Care Center. This is our most common one, is a figure 8. So one probably studied the most next to the brainsway, the H coil. And what you see there is that very deep yellow. When you put two poles together, the physics of it has it concentrate into one area. It's almost a cone effect in a sense that it is able to go deep and then repetitive. And so we can hit these areas and actually focus on them. So the old technology that I got trained on, so I'm a tad older, I don't know anybody's age group in here, is on electroconvulsive therapy. It works. It's amazing. The numbers are actually a little bit better than TMS when you start looking at major depression. But to do ECT, I need an OR, I need a nurse, I need an anesthesiologist. We actually induce a seizure into a whole hemisphere of the brain. So it's not very directed. Use a military term, I'm using a lot of artillery with ECT. This one is much more directed. And so after this is what we're going to show. We're going to make this very customizable. And the customizable is a mapping portion that we do to induce an action potential in their hand, right? Into the pollex brevis, and the first index finger is usually what you want to hit. But anywhere in the hand, because we're talking millimeters, this is what we're inducing. We're trying to use the least amount of Tesla, the least amount of power to induce an activity. So if I can move Alex's hand, and when I go to the treatment, I know that I'm inducing neuronal activity into that area. And I could, once again, depending on where I'm going, it could be turn something on or turn something off, or engaging in what the brain is already doing, but enhancing those things, especially when there's a deficit, right? And so I'd like to demonstrate what this motor threshold is here with Alex, okay? So, sure. So we've already set this on the MagVenture, okay? And we can kind of direct it. Now, when we actually do a true mapping, we do have a cap. We measure things from your nasion to inion. We look exactly from where your motor cortex is. But after doing about 800 or so of these, you can pretty much do it in my sleep, right? But that being said, we will, when the patient comes in, any of your referrals that come in, we'll make sure and we'll do all of the measurements that are exact. But for this demonstration purposes, so this is about the same Tesla as an MRI. Okay, so you hear a little bit, and that is the magnetic pulse going, and it's going to create electric charge. So on his motor cortex, each one of these areas has a specific area of the body. Right? And so approximately here is where we have for the finger and thumb. Making sure that the amplitude here, right? And okay, so a little bit of a delay here with the video and stuff, but you see that we have a little bit of a movement. And so what we really want to do when we actually do this is to use the least amount of Tesla in order to produce this. So we put this a little bit higher, one, to show it does not hurt. You okay? Doing great. Doing great, good. Yeah, so it does not hurt at all. It's non-invasive, but we really want to use just a minimal kind of movement there to use the least amount. I like to go slow and low, But I like to also follow the evidence that has been showed both in the FDA and also in some non-FDA. You okay? Great. Slide. All right, so here are some of the logistics, and just to kind of go over it, usually what the FDA asks for is 5 days a week for about 6 weeks, right? And that's kind of what we look at for major depression disorder. I have had people come in and they respond to 9 to 11 weeks, as well as some people that can't do 5 days a week. So we work with that patient to try to do whatever we can to assist them. The best evidence is the 5 days a week for about 20 or 30 minutes. Because I also here at Family Care Center, I like to use 2 different waveforms, and we're about to produce a poster at the TMS Clinical Society, kind of showing this bilateral approach for depression, general anxiety, PTSD, and social phobia, and how we have gotten a response, especially by using different hertz and different locations, right? But the most common area is going to be on the left side, the dorsal lateral cortex. Where we have the most evidence, the most meta-analysis of what's going on. The cool thing is with this is that there is no restrictions on activity. So instead of like having that ECT, you're able to go back to work, go do your things, go to school, and go on with your day because it is non-invasive. And we have a question.
Yeah, Dr. Weber, we have a question. Who came up with the 5 days a week, 6 week frequency, and why is it a 20 to 30 minute duration?
Yeah, so that's going to be based on both the technology and the studies basically from the 90s. So what they found was they tried a lot of different protocols to do it 1 day a week, and there's also something called a Stanford protocol or a Saint protocol, which is about 6 sessions all in 1 day. So you actually do all 30 sessions in 5 days. So there we are looking and studying on the frequency and the intensity of that. Now, the meta-analysis that I'd like to follow is the one that has the strongest evidence. And that strongest evidence is that 5 days a week. Now, I say 20 minutes is because there's a repetitive TMS. I can also use an intermittent TMS or a theta burst, and that's approximately 3 minutes. What I like to do is usually couple those things, especially if they come with comorbidities, in other words, other diagnoses. Because not a lot of people come with just depression. So, especially here at Family Care Center, we don't do like research in the sense of research subjects. So I try to base it on the literature that is out there. There's a lot of people that have done this that are much smarter than me, and I want to make sure to keep people safe. That answer your question?
Thanks.
Yep. Okay. So here at FCC, we also use the MagVenture, and we also have a BrainsWave machine, right? And so we're going to go through a little bit on what that BrainsWave and how it's a little bit different. MagVenture does allow me to go to a lot of specific areas and to hit a much more precise kind of area. But the H coil here, it's the middle coil that you see on the BrainsWaves will be used here. This is actually used also for OCD. It can be used for depression, anxious depression, and there's even a smoking cessation FDA approval. Now, the insurance has really kind of blocked us on most things except for major depression disorder. But at FCC, we do have a sliding scale and a way to work with anybody if they don't actually meet the criteria for major depression disorder. But the H coil is very, very interesting. It goes down a couple centimeters deeper than the MagVenture. It does hit a wider area. So what we've seen in some of these studies, especially with OCD, areas that we need to hit with the anterior cingulate, ventral tegmental area, these are the areas that the H coil can. Interestingly enough, is BrainsWave is also doing a lot of studies with post-stroke victims, as well as Alzheimer's, Parkinson's. The deeper that we go, that we can actually kind of enact a little bit more neuromodulation. Yes, sir.
The question is, do patients who are receiving treatment for major depression with TMS and are active smokers, do they benefit from that treatment for major depression?
Yes, that's a great question. And yes, the protocol for smoking cessation is only about 10 sessions, right? The studies are a lot less, and the meta-analysis are not as strong as this. But what we can see is definitely it's probably the number one thing is cueing. And so the cues go down, and some of the stress associated with it. So we kind of see a less smoking usage. The complete smoking cessation, to be completely off of it, it's probably going to take more than the 10 sessions. But in 10 sessions, Most of the studies have showed a 50% reduction of cigarette use, which is great. All right, so a lot of my meds have side effects, right? There is a place for them. I'm a psychiatrist, I'm also addiction survey. So yes, there is a place for this, but if you can look by everything on that left side, sometimes we pick a med based on their side effect, unfortunately. And then if we do get a med that works, sometimes I have to give you another med to get you off of that side effect. So it is really a struggling dilemma sometimes for med management. When you look at TMS, you're talking about possibly a little bit of a slight headache, usually the first couple sessions. And the way that we do it at FCC is a very slow titration because I don't even want that headache. I mean, it should be a little bit weird and annoying, is what I tell patients, but never painful, right? And then there is a very rare chance of a seizure. Most of the studies have been 1 in 30,000. Next slide. Okay.
There's a question, sir. Has there been research on THC addiction treatment?
Yes, there is a lot of studies going on. Most of them are in Europe. It's probably got the best studies. Now, SUD is a place that I think that the literature is not as strong. And I will tell you, anecdotally, been doing this for 7 years. And like I said, I've done over 800 mappings and remappings and overseen 30,000 TMS sessions. So my habitual THC users, the ones that do not want to stop, and they do it every day, they don't usually respond in 30 sessions. So some of the averages are around 50 to 60 sessions, right? Now, if we can get the person to try to cut down on their THC usage, then of course that lowers the number. But if they do not want to stop at all, of course we meet a patient where they're at. Motivational interviewing for anybody who has addiction out there, it does take about almost double the amount of TMS sessions to try to get into a reduction of PHQ-9 or the HAM-D, because we use measurement-based care here as well at FCC. All right, this goes down to our efficacy. So here are some of the meta-analysis. We have the citation up here. It does go looking at both psychopharmacology and therapy, and then what TMS does. But just to kind of, at least the data that we have right now, we've been collecting for a few years, when we do take the approaches at FCC, especially when we use 2 different waveforms, our response to major depression disorder measured by the PHQ-9 and also what's going on with their symptoms is around 78%. And then there's about a 35% remission. What that means is a PHQ-9 underneath 5, where we can usually get people off certain meds, reduced dosage, or off of meds completely. And so I know every patient usually wants that, but for the most part, that full remission is something that we always strive for. A 78% response rate, that pretty much beats anything that my meds can do. You have questions?
We have a couple of questions, if you could field these. The first one is about insurance. Is the copay with insurance and Medicare at the specialist amount or rate? And is there a copay for each treatment?
So we have specialists, a whole TMS intake department that knows all of the insurances and they move the goalposts quite a lot. I do not remember Medicare having a copay at all with that, but I would have to kind of defer to the TMS intake, and you can put down either your email if you associate with one. We can make sure and have a TMS intake give you a call and let you know what that is. But there are some that do not have a copay. There are some that have deductibles. Thank God I'm trying to focus on the chief medical officer and try doing clinical, and I have a whole department that does that. So I don't have the specific answer for you on that, but if you do get that, we'll get that for you. Okay.
And the next question is, are patients with seizure disorders able to participate in TMS?
Yes. And so if you saw that other slide, it is a relative contraindication. I have treated 20-ish so off the top of my head people with seizure disorders, but they've been stable. Right. And so when I say stable, usually what that means is about a year on meds, seizure-free, right? And so if they're doing that, I've done TMS very successfully on that. So the seizure risk is very, very low. And we really, after doing the motor threshold, we've stayed away from that motor cortex and sensory cortex completely. Almost all of that's focused on the prefrontal cortex, which we'll get through later. Okay. And kind of this might answer some of your questions. So insurance puts some barriers up there, right? The FDA has said one failed med and a major depression disorder, you're refractory. But the insurances sometimes ask for 2 to 4. They ask for augmentation. They ask for therapy failures. They happen within this episode. I mean, it starts getting down into some delineations, and we have an operations TMS person, and like I said, that TMS intake, they move a lot according to, and they look at the insurances very much so. Now, really, most insurances will all cover major depression disorder, except for Medicaid in Colorado. And also Cigna, I believe, does cover OCD. But for the most part, it's if you have MDD and any comorbidity, that's okay to get usually approved by their insurances. Okay, so just to kind of go over this, I know a big, broad kind of based aspect is that it is very well tolerated. It is FDA cleared, right? And we have some of those indications over there that we talked about, and then some of the non-FDA indications. Where I probably had the best success is for PTSD, general anxiety, social phobia, and my responses on neuropathic pain, it is about a 50%, to be honest, with there, but that is neuropathic pain. It's not chronic pain. So there is a different pathway with that. And what we really like to see is that lack of response of medications. And if you are taking care of them, either you're the med provider or you're the therapist, and we're delivering TMS, we want to communicate to you when those things are happening. Because a lot of patients want to taper off their meds right away before all their sessions or before there's been a response rate. So communication, when you refer your patients to us, is really pivotal. And I think that we have to do that. There's so much demand out there. We need to partner with all of our referral places and our other providers. Psychiatry is a team sport, as they say. All right. So we're going to get a little bit on, this might go a little bit more on the science kind of side, but I really want to show that we're a neurochemical machine up here on what is going on with the neuromodulation. When I say neuromodulation, we are changing the pathways, right? So this also happens in therapy. Right? If you're doing CBT, you have a bias, an automatic thought that actually leads into a reaction. You have a pathway that you've solidified over and over again, possibly in a negative way. Therapy actually helps reroute that, utilizing a neuromodulation. And so if we're coupling that kind of even therapy, our meds, they act on the neurons, but we really don't have a lot of neuroplasticity with our meds. But when we couple it with TMS, you're going to see some major changes. So I don't know all of our audience out there, so we're just doing very, very kind of basic. The frontal cortex is where we do most all the treatments, right? There is some protocols for the posterior, but we rarely do those. Most of these are going to be all in the frontal. And this is the executive functioning. These are the things that are making us human. It helps us both process things, to execute things, and then also really, I guess, what makes us human in the sense of how we express and how we interact with stimuli on the outside. Now, there's no test on this, so don't worry, right? But it's to show you that when we actually have a magnetic pulse creating an electric charge, it does follow a pathway. Some of these I might just point out are they're all kind of routing back into the limbic system, our emotional center, right? So something with the anterior cingulate, it's got two sides, a dorsal and ventral. So one might be more cognition, and the other one's kind of connecting into that emotional kind of response. And, when we enact with these pathways, we're actually affecting all of the things that are associated with it. That's called like a feedback loop. So that's where we turn things on or turn things off. So when we're showing you some of these, some of these radiological scans, I just wanted to be very basic and kind of let you know, if you haven't seen one before, what those high activity and no activity kind of look like, okay? Basically red and yellow, much brighter, and as you go lower in the hue, that's less activity. So if you can take a look at this, I really like this in the sense of showing what a normal brain is, and we shouldn't say normal. I don't see anything normal with psychiatry, right? I haven't met anybody. So a brain that does not have a diagnosis, how about that? And now we have depression. So this is actually looking up. And so that left side, when you're looking up from this, so this particular cut is showing that left side. And you're seeing that activity is not going on that depressed brain. Okay? For bipolar, there is a lot. There's both a depression aspect to it, but also some of the activity is in a different place. And this is kind of showing a little bit more temporal parietal, but also that frontal cortex is not firing like it should be. And of course, schizophrenia has too much, and then OCD, There's a lot of activity, especially when we're talking about that anterior cingulate ventral tegmental area. Okay. Now, just to show a little bit more on that depression, showing these different kind of cuts and these different kind of radiological. So we're looking at some of these kind of, you're kind of seeing that, hey, everything is bright, and the movies have it wrong. We are supposed to have use of all of our brain, but people that are depressed, especially chronically, looking at that frontal cortex, it is just not turned on, right? And so that is kind of what we want to do. We want to turn on that left side of the dorsal lateral radial cortex. But you can see it's actually less active or hypoactive on both sides. So as we're kind of moving towards conclusion, we want to let you know, it's like sometimes you might not know there's a therapist out there, a nurse case manager, and you're like, hey, how do we even get some information here? We even have a no-cost consultation. So we have one of our med providers that take a look at you. They kind of go through your history, and then, of course, we have that professional intake department that kind of works with the insurance and jumps through all of their hoops. We will do all of that for you. The biggest thing is you refer to us, and we're sending your patient back. You're taking care of meds or therapy or whatnot. We're going to augment that and communicate with you because we really want to be partners with you. All right, so here are our top five, and our top five is just to let you know that a little bit of an introduction of what TMS is. And, it just is not as well understood, even though it's been around since the 90s, FDA approved since 2008, and that, even though it's daily or it should be daily, it doesn't have to be. We're going to find a schedule that works for the patient as well. And then there's a lot of indications and there's a lot of clinical evidence for some of those non-FDA approaches. As we're going, this neuromodulation is expanding. All right. So hopefully that you show that's safe and effective. Alex is still alive here. Yeah. And I think that Trevor is going to move for all of you guys showing up. There's a randomly, we actually do have it. See, it wasn't, there's no smoke and mirrors. We actually have the iPad here that we are going to give away to thank you all for your time and thank you for your attention to this. Of course, after we do this, I'm also open to any other questions. Go ahead, Trevor.
Awesome. Thank you, Dr. Weber and Alex, for the awesome demonstration. I just put in all of the names into our random picker wheel here on online, and I just spun it. And I don't think you can see it right here. Nope, it's blurred out. But Catherine Roybal is the winner of the iPad Mini today. Congratulations, Catherine. I will be reaching out to you directly after this via email just to get shipping information to send that over your way. But we do really appreciate everybody else jumping on today. We have a couple little bits of information here as far as the contact us information for TMS. That 833-FCC-4-TMS number is our intake department that can answer any TMS-specific questions around insurance, scheduling, etc. Also, do check out our website at www.fccwellbeing.com. If there are any additional questions before anyone wants to take off, do feel free to put those ahead in the Q&A, and we can go ahead and answer those. But otherwise, we do appreciate all of your time today. And again, thank you very, very much for coming in. Let's see. It looks like there's
a question.
Yeah, Andrew, go ahead and take that one.
Sorry, the question is, as a mental health counselor, I'm familiar with TMS. When I mention it to clients, is there a basic and quick way to describe what is to clients who are unfamiliar with it?
Yeah, well, we have on our website, we have a QR code as well that kind of leads you to a very basic. I also have some videos that some of them are about 30 seconds to anywhere from like 3 minutes, kind of describing. I think there's 13 of some frequently asked questions that we always get. And so if there's a way to maybe take a look at that and find something that kind of works for your narrative, but for the most part, what I say is a very non-invasive approach. It's a chance to get off medication, to use what your brain is already making through magnets, which have very little no side effects. Next one.
All right. So the next question would be, why choose FCC over other providers that provide TMS?
Sure. So, I believe that we are different in the sense of, one is the approach that we have, some of our remission rates, and also that we do have that collaboration. So I am not a TMS center, right? I believe TMS has incredible potential, and I love it a lot more than meds. In fact, I don't really take any new med providers because I do so much TMS. I still see patients, but those I've seen for years, right? And so what I really believe is that both our approach and the environment that we kind of create and our flexibility to kind of see the whole picture. If I'm just doing TMS or I'm just a TMS kind of center, I was saying in the military, if all you have is a hammer, then everything's a nail. So I like to look at things as the whole picture in the biopsychosocial spiritual, work with those counselors on the outside or those med providers on the outside, how we work together to get the patient better. So I'm not sure if every place uses that approach. Whenever we do have our referral partners and we share a patient, they've always expressed that it's a very new experience here at FCC because of that collaboration.
There's a question from a med provider. They're asking, can I continue managing my patient's medication if I refer them to TMS?
Absolutely. Yeah. So, I mean, this is where we want to have that partnership. The demand is huge for mental health. And so the more patients that we can help, the more community impact we can do. Yes. So I tell people, use this like a buffet. If you're a med provider, use therapy and TMS, it's fine. If you're a therapist, want to use this in your practice with both, you just want to use TMS, yes. Whatever it is that you want, you keep your patients and we coordinate, communicate. That is really pivotal to me. There is such a demand out there, and we have good providers, we have good relationships. I think patients are the ones that are going to benefit.
We have a great next question. Why should I recommend TMS to my patient versus ketamine or psychedelic?
Sure. So I had a ketamine business for about 3 years. And ketamine does have a place. The best literature is in urgent care, right? The thing with ketamine is that what I saw over the years and what the literature kind of backs me up is it tends not to work as long, right? And so when you get probably about 6 weeks to 3 months worth of relief, some of that is amazing. What if they actually acted and did a lot of therapy during that time? I really believe that when we couple that, there is some success with that, but you're not going to have sustainability. TMS has durability. So some of my patients, they don't come back in a good way. Some may come back in 6 months to a year. Some I remap in about 2 to 3 years. Ketamine does not have that. Most of the patients, when they got the benefit, they would have to come back sometimes weekly or 2 weeks or sometimes every month. And also insurance didn't cover it. Now, S-ketamine is covered, but it has about 20% less efficacy than the infusion model. And so I didn't really like some of the S-ketamine aspects, but once again, the literature is there. The patient can get better, that's great. Now, LSD is another thing. I think some of the approaches are going to be very interesting, but it's very, very young in its age. And it has not been studied to me to be evidence-based yet, but at least as a psychiatrist and kind of neuroscientist aspect, it looks like it has potential to be phenomenal. But right now, I don't think I would, I'd say treat everyone like your family, let someone else treat your family. Would not give this to my family.
That's a great segue for the next question, which would be our final question. If you were suffering from major depression that was resistant to therapy and medication, would you yourself participate in TMS?
Yes, absolutely. And I think as we practice, we've probably given each other enough TMS to actually go through a whole session. Because we do both, when we do the manufacturer's training, we also have a TMS training protocol here, especially with our TMS staff. What's that like being TMS staff here?
It's really wonderful being able to work with bed management, therapists, all connectively to get this patient to a better place is just something I've not seen anywhere, even in my own life with mental health care. Being able to have all my providers communicate for my best outcome is probably the coolest thing. And see a lot of patients like that.
And so, yes, and what I'd say is we do treat because we have 15 locations. The only thing we've got so many providers, I think it's about 155 providers over the state of Colorado, is that we actually care for each other, but we just don't do it at that same time. So we're big enough that we can actually take care of our family. Family care center.